All right. Hello. So glad to be here today. Thanks for having us. I'm here today. My name's Alice Harvey. I'm representing a couple of different groups, Home Key Health and also the Resilient Care Alliance. So we're here today to tell you a little bit about both of those things, both initiatives. These are both new groups that we've just formed, newly formed in our valleys that we're hoping to use as a vehicle to move forward the interests of home-based care in our valleys. And when I say the valleys, I mean Roaring Fork, Eagle River, really Garfield, Eagle, and Pitkin counties, where we know that home-based care has been a struggle really to sustain in the last decade. And now more than ever is the time I think we all need to join together to try to build a more strong and resilient healthcare ecosystem in our valleys, especially surrounding home-based supports. It's so very important. So without further ado, I'm going to go ahead and get started. A little bit about myself. Don't want to spend too much time on my background, but I have been here at this conference actually a few times wearing different hats. I'm back wearing a different hat. What do you know? It's actually pretty common in our valley, I've noticed. We call it the professional musical chairs. Not a bad thing. I think it's part of the nature of what we do as healthcare providers in the community health space. It not only takes a village, it takes this sort of forever rotating, evolving group of villagers to do what we do and to care for each other. So I started actually, I came to Northwest Colorado over a decade ago now to work in Meeker, Colorado at a Pioneers Medical Center, Rural Access Hospital. I'm sure you're all familiar with. I started a population health program there and then moved on to public health. I always joke and say it was April of 2019 when I chose to go into public health. So it was one of the worst timed career decisions I ever made. Just kidding. In trueness, it was probably one of the best. I was very privileged to be part of the public health leadership during a time when my community really needed it the most. So did public health for a while. In 2022, I had moved to Eagle County to lead the community paramedic program through Eagle County Paramedic Services, which some of you may be familiar with, and also start a home health program through our district as we were continuing to see home care and home-based services just continue to recede. So I've been in the community health space here in the Western Slope for a while now. My colleague, Heather Babcock, is here with us as well. She has also had a similar journey over the past decade in Western Colorado as a provider. So I'm happy to have her here with me as well. So enough about us. We are sharing today two things. We're going to be sharing what my colleague Heather and I are doing with our new home health agency called Home Key Health, but we're also going to be sharing some about a bigger project, an umbrella project, if you will, that we've been working on called the Resilient Care Alliance. This is a nonprofit. It's been started by not just us, but another group, a bigger group of providers and folks trying to advance the home-based care cause here in our valleys. So let me go ahead and get started. Let's just move along. So I'm preaching to the choir here, and I definitely, I'm not one to beat around a bush. There's no need to, especially not in front of a group like this. We all know the problem. Staffing is a huge problem for many, many reasons. Again, I'm preaching to the choir here, but we know that in rural Colorado, and this is actually part of the new data that has just been published or was recently published in the 2026 data snapshot from the Colorado Rural Health Center, there are only 25 home health agencies registered with Medicare in rural Colorado, 25 total for all of rural Colorado. We know that rural Colorado makes up a big percentage of our state. So it's 11% actually of all the home health agencies in the state are located in rural areas. In our three counties that we're representing, we have a grand total of three, two that are providing home health skilled services, one providing hospice, only one of those that is owned or operated in one of the three counties, and no services in Pitkin. So, we understand that access to home health is a struggle. I'd like to talk more today about why we are seeing this perfect storm. What is the reason? Some of these reasons are obvious. We understand that Colorado is experiencing one of the nation's fastest rates of population aging. Yet our healthcare workforce is simultaneously dwindling. And this is due to astronomical property values. This is ironically, of course, then driven by the influx of second homeowners and retirees who need our services the most. So it's we call it the paradox. It's the aging paradox here in Colorado. But we also know there's been a lot of changes recently in reimbursement for home health, which has not helped rural agencies anywhere in the United States, definitely in Colorado, where we are experiencing, again, one of those fastest aging rates. So just a couple of things, just diving in, you see the various things noted here on the slide. We understand there's a worker shortage. We understand there's decreasing compensation and a higher cost of living. Those things alone, along with the demographic shift, sort of give us the obvious answer as to why we're seeing such a hard time with sustainability of home health agency and existence and sustainability and staffing. But we also, want to talk a little bit about what that means downstream to patients. So in terms of access to care, especially for an aging population, we understand that home-based care is not only, we know the evidence shows that the care and support that a patient has in their home environment is the most important, or definitely one of the most important in terms of overall health outcomes. But when we talk about access, again, this comes from that rural health data snapshot just recently published. Access for older adults to home care, to home health care in rural areas is 44% lower than it is for their urban counterparts. It's 78% lower for home-based support services, which we all know is just as important as skilled home health. So the reality is there is a shortage of home health workers in our area. Any agency, which again is why we're here today to talk a little bit about is why agencies can't sustain without this workforce. The answer seems very intrinsic. Clearly, we need staff to provide services, to provide hands-on care. But another part of that is the reimbursement and compensation model that we're seeing federally and how that's trickled down. So just in case some of you may be more familiar than others. If you're in the billing space, of course, this is not any news to you, but the PDGM model that went into effect January 1st, 2020. And of course, again, terrible timing, right? Right when we were getting hit with a pandemic, which added its own challenges in terms of staffing and sustainability and workforce. But this was one of the most significant overhauls of home health reimbursement in over 2 decades in our country. It hurt rural home health care providers in many ways. It made it harder for agencies with lower volumes and higher travel costs to stay in the black. This was in part due to sort of the shift from therapy thresholds and the by visit model, reimbursement model, to the clinical characteristic model for reimbursement, which basically means that you are getting paid based on the patient's clinical presentation, not necessarily how many visits it takes to care for said patient, which by its very nature in rural areas, of course, it's harder and more challenging and more expensive to provide those cares per visit. So that hurt us a lot. The 60 to 30-day billing cycle, there's a higher risk for low utilization payment adjustments, despite travel costs and administrative burdens. So that also affected rural agencies. And then finally, the phase out of the rural add-on. The rural add-on was a staple for a long time for our rural agencies. And that was a percentage increase in payment for services provided in rural areas to help cover those higher costs and those inflated costs. It was an economies of scale solution that CMS employed to make sure that rural home health agencies stayed afloat. And that's now gone as well. So increased overhead already, which we know about, higher risk of lower payments, and then that loss of the rural add-ons really just resulted in the inability of any home health agency, let alone a startup or newer local-based agency, to really sustain services in rural areas. The downstream consequence, as you all know, is delayed care, burnt out staff, and then patients falling through the cracks, which is the problem. So we are not just looking for more bodies. It's not as simple as a one-step solution like more housing or more bodies, right? We are looking for a better system that's sustainable. We can't just keep doing the same thing over and over again and expect it to work. Nor, unfortunately, can we anticipate that CMS is going to wave a magic wand and come and save us all. No matter who's in charge, that's not happening, unfortunately. So moving on again, let's just talk a little bit about what we are as a new home health startup proposing that's different. Again, we could decide, to start a business. Anyone can decide to start a home health care business in our area. In fact, have over the years. And unfortunately, if you don't have a lot of money, a lot of just capital, operating budget, which we do not, um, it's a daunting task. Okay, you're already operating in the red. We are operating in the red. There's no, there's no reason for me to candy coat it, as you can imagine. And I'm not here today to talk to you about like, business planning and modeling, because we know that's a topic in and of itself in healthcare. How are we going to fix the bigger healthcare problem? But I'm going to get there by just sharing with you all what we're doing and how we're doing it differently. Because again, starting from square one, we have to come up with something innovative. We know that, or we will fail just as quickly as we started. So, Homekey Health, we're trying to be innovative. Part of our presentation today, two-part presentation, we're going to talk to you about what we're doing with Homekey Health, and then we're also going to talk to you about what we're doing with the Resilient Care Alliance. Both are related. We're hoping that we can help each other grow. The Resilient Care Alliance, I'll talk about more in just a moment, is a way that we're hoping we can help other agencies like ours and existing agencies to be more sustainable, more successful, therefore solving those gaps we talked about in the last slide. But what are we doing with Homekey Health? So my friend Heather and I mentioned, Heather's a provider. She works at Valley View as a hospitalist. She's been in the area as well for over a decade. And we have worked in the Western Colorado healthcare system long enough now that we actually we're very proud of the fact that we are starting this company as locals, as local connections, for locals, for our neighbors. So we're not starting from a place of a franchise that's based outside of our communities. We're truly doing this as a grassroots startup. We came here for rural medicine. So we not only wanted to raise our families here in the mountains, we had that frontier spirit like all of us have that live here, but we were attracted to rural healthcare, and there's nothing like it. I told you I came from Pioneers Medical Center in Meeker, and there's really, I could sit here and tell the stories. The benefit and the value of working in rural healthcare is truly so many things. Being able to wear all the hats, that's part of why we're here, right? We know it's going to be difficult. We know we're going to have to wear these different hats every day. But the great part, it's not so much the sensational parts that I can talk about, like, of course, working in a rural hospital, knowing that you're the only nurse on a night shift. Literally, if you need a doctor, I was told when I first came to PMC, I would need to call 911. And the sheriff's deputy would go out to the home of the medical provider that night, knock on the door, and literally give them a ride to the hospital in a cop car. So that's not a joke. Cell service was not and still isn't the greatest in rural areas. So, people in bigger cities, people from urban centers, like where I came from originally, it's mind blowing and it's not a joke. But that's not why we do it. We do it because we have this opportunity to make a difference with caring for your neighbors. You don't have to just do the quick one in, one out visit, primary care, ER, whatever you want to say. You don't have to do that. You get to take your time. You get to act as patient advocate, nurse, case manager, caregiver, primary care coordinator, all in one for the people whom you live amongst. So that is it. That's why. That's why rural healthcare is so appealing to some people. That's why Heather and I both came to the mountains to do that type of work. And we have been ever since. I always think about Dunbar's number. I don't know if you guys are familiar with this sociological concept. I love talking about it in any presentation I do because it's always relevant. Dunbar's number, this is a British anthropologist who presented this idea in the 90s. It's this concept that's actually foundational now in sociology and psychology. It just basically supports this idea that a group, once it exceeds a certain number, and that number is lower than you think, the natural ability to communicate breaks down. We are tribal creatures. In the end of the day, humans are tribal creatures. We need one another. And in order to stay cohesive, the bigger a group grows, the more layers have to be implemented that become impersonal. I think this idea, this concept really illustrates why our federal healthcare system is broken. It's bureaucratic and it's broken. So if we're going to fix it, we have to fix it by bringing care back to our communities and control on the community level. So we're bringing it home, and then we're also leveraging technology, the best of what's out there. It seems, again, almost obvious, but it's more than just an app or a automatic blood pressure cuff. When we look at remote patient monitoring and telehealth and all of the different diagnostic tools now that are at our disposal, this day and age, also just the internet, being connected, we have to realize that this is something we can leverage to strengthen our healthcare system, and we have to. We're at the precipice of this new way of delivering healthcare. It's not a new novel idea, but what we want to do is make it available and affordable for individuals, and then also for care groups, for providers, clinics, hospitals, to extend their care into the home of rural patients. Again, this is not focused on, using technology to bring in, outside corporate providers who don't know our communities, and even with the best intentions, but focusing on strengthening what we already have here. And this means providing in-home care coordination and nursing services that are powered by technology. So we are a clinician-like company. We've got two different really key technological innovations and ways that we're revolutionizing home health care. Our patients are connected to remote patient monitoring devices. So this is to enhance, again, not to replace, but to enhance their care. We're hoping to bring primary care providers into the patient's living room, bring their data to the providers so that they can better serve them. Break down those geographical and barriers that often we experience in trying to seek healthcare resources in these types of mountain communities where we live. The other thing we're also doing along with remote patient monitoring is what we're coining geo-staffing. And this is a unique care model where we're essentially using a technology platform. It's essentially an app to find clinicians to practice and care for their neighbors in their local area. It's a contract model. So we're giving providers the opportunity to pick up jobs and help people who, again, live in their neighborhood that that can work within their schedules. If you are, and we know, right, like whether it's blood pressure, oxygen, glucose, weight, fall detection, there's an app for everything. We're kind of tired of hearing this. When you're an older adult and you have limited experience with high-tech apps, that doesn't mean anything to you. So we're trying to bring it all together to put that technology at people's fingertips with a human who lives in their neighborhood to help care for them. So the staffing model, we're allowing clinicians to practice at the top of their license. We're monitoring patients more safely with the remote patient monitoring. We have advanced practice provider consultation and oversight. And a way I like to explain this to people, if you are having a hard time wrapping your head around it, is, have you heard of Rover? If you haven't heard of Rover, it's an app that's been around now. It's similar to Uber and DoorDash, where someone can open a phone, open an app, and find someone who can walk their dog that wants to make a little extra money, that lives in their neighborhood, and they can book it right there from their phone. If we can do it for our pets, it goes without saying, we should be doing this for our community members who are struggling to age in place. So we're bringing back, in a way, right, the horse and buggy, okay, the house calls. In a way, we are. Our medical director, Dr. Kruger, may love that if we told him he got to saddle up and go start seeing patients again. But I'm just kidding, not again. He never did it on a horse. The answer is yes and no. We are bringing back the house call, but with cutting edge and creative technology and clinicians who are enthusiastic about making a living in their communities and caring for those people whom they live amongst. So that is the idea of Homekey Health. So we are accepting patients. We are a licensed, skilled Part A home health agency. We're also doing Part B, so we will be hiring caregivers as well. So we'll be doing both skilled and non-skilled care. And I'll talk at the end of the presentation about how you can refer. That's one thing. We have information. We're excited to be that fourth agency, but we are the first and the only one that will be covering all 3 counties and will be led and based in our counties. So probably more important than that, and I'm more than happy to take questions about Homekey Health after this presentation, but I want to move on to the important stuff, and this is the Resilient Care Alliance. So we're attempting, this is a nonprofit. This is what we're attempting to do with this new nonprofit organization. It was just formed a few months ago for Garford, Eagle, and Pitkin counties, is basically find a way to collaborate with all other folks, agencies, providers, individuals, clinicians who are attempting to do the same thing we are, who see the need for community-based care. We'd like to get everyone together on the same page. So it's not just us. Alice and Heather would change the world, if we could alone, but we've been trying to do that now for a few decades and with some success, I'd say. Just kidding. It takes a village. And we all know, hence why we're here, hence the WHA, Valley Health Alliance, why we're all here today. So this was the brainchild of not just us, but a group of other folks who are either actively providing or trying to provide home health services in our valleys. We recognize there's so many barriers and hurdles for agencies to succeed here, which we've already talked about, let alone for a startup that isn't backed by a larger corporation. So we've got individual clinicians, home caregivers, therapists, private nurses, for example. There are so many prohibitive barriers that we have to billing, compensation, sustainability. We've got to find a way to share resources. So so far, we're very small. We have a handful of founders. We've got a board of directors formed. We do have our nonprofit status, and soon, actually starting today, we're going to be opening our membership to anyone and everyone that wants to join. So this can be established agencies, which we know there are only a few. We've already connected with some of them, new agencies, and then individuals, other care systems, hospitals, clinics, many of who are represented here today. But our goal is to host monthly educational meetings, join forces with staffing and recruitment, and ultimately, hopefully, pursue joint fundraising. Our mission statement is we are committed to enhancing access and a care system that has historically been underserved in rural areas. We aim to support a resilient, sustainable home-based care ecosystem by strengthening new agencies, encouraging responsible growth, and building together so that home health and hospice services in our region remain stable and readily available for community members to age safely in place in our mountain communities. So it's a lofty goal, it's a lofty mission, but we know we can do it. Moving on, I do want to share, we are hoping through the RCA to essentially access some of those RHTP funding opportunities. We're not naive to the idea that this is, it's the elephant in the room, right? It's those big 5 pillars. We know that Colorado has just received a lot of funding, and that very soon that funding will be making its way to our local health systems. Whomever the recipients of those dollars are, we don't know yet. We don't really care. As a group, we just want to be here and hopefully find a way to collaborate with those recipients to ensure that CDPHE's mission for those dollars is realized locally. And it all boils down to us bringing as much of that funding into our communities that we can. The 5 pillars, if you're not familiar with RHTP funding, right now, our first round of funding, Colorado just received $200 million. The 5 pillars are regional collaboration, innovative care models, workforce development, chronic disease management, and technology and infrastructure. Sound familiar, right? That's what we're here to talk about today. So I can't emphasize enough. We're not here to present some kind of profit-making solution that will benefit, a home office somewhere else. We're here to rally the troops and hopefully gain your support, and if anything, your ear and your voice. So join us today. We are open and available to accept referrals. We have some information in the back for HomeKey. Just so you know, we are providing home health skilled and non-skilled care. We are live. Our Medicare and private pay applications are in process. We do have a very manageable sliding scale fee for private care now as we speak. This includes a very low cost option for those who are even uninsured or low income. So we recognize, again, one of the barriers, getting registered, getting to where we can receive insurance dollars is hard, but we're doing it. We're doing it from the ground up. But most importantly, we want you to spread the word. Take this back to your agencies, your partners, and we'd like for you to join us. So we do have a sign-up sheet in the back of the room for the Resilient Care Alliance. We're building this safety net. We are just getting started, so we'd love to hear from you. Anyone in this area who is in any way serving patients in their homes or needs a way to be able to share resources into the patient's home, because that can really be anybody. We'd like for you to leave your email with us so we can send you information about what's happening with the RCA. Feel free to email us with information. Next week, I'll be sending out an invite list with some of our first events that we're hoping to plan. We do have some events already planned and coming up. We've got 3, 1 in each county through the months of May and July. We're co-hosting these as HomeKey Health and also with the RCA. We focused on workforce development and staffing. So if you're interested, please send us your information. And of course, share it with any other caregivers in the Valley that are either looking for work or looking for support. So without further ado, I'd like to move on to just a fun activity we're going to do. It's called the Village Scalability Test, just for fun. Before I do that, though, any questions about what I've presented, who we are, and what we're trying to do? I know this is rapid fire, but I'd love to take questions.